so easy for me to speak or to have such lecture. That's why I'm looking for PET-CT. First of all, I need PET-CT as a role. It's initial diagnosis. It's helped me in initial diagnosis. Secondly, for staging, accuracy, and prognostic values. And the third thing here, can you? Okay. For sponsor assessment and post-treatment, that's what I'm asking. I'm a clinician. So why do I need such PET-CT? Actually, I am a fan of PET-CT. It's maybe 15 years ago or more. It's the first PET-CT was in international clinical international. I think it's في العالمي in Swiss in Cairo. I went there to learn what about PET-CT. So the utility of PET-CT in hematological malignancies, for me, it's for detecting disease extent, spread, assessment of response, and impact of treatment planning. That's true. What about monitoring? You can monitoring PET-CT for detecting residual or recurrent disease, identifying transformation to aggressive disease, assessment of bone marrow involvement. This is very important for me, especially in lymphomas or myelomas. What is the challenges of limitation of PET-CT for me? Can you differentiate between benign and malignant lesions? First, yes. For XZ1, yes. It's very good for me. It's as sensitive to small lesions. I think it's maybe. And impact of planetary process. So I think when you going when I'm going to ask for PET-CT, I'm avoid two things. Previous or recent infections, which may affect PET-CT decisions. Secondly, use of GSF, chronic factors, take care of this point. And I think in future you need to have a checklist from me, first of all, which includes first diagnosis, subtypes of this, especially in lymphomas, recent infections, and recent drug used as steroids, actually. This is, I think it's very important. I know you ask about one thing, what about diabetes and controlling diabetes? No, you need more to be accurate for this. You need a collaboration between both clinicians and you. And I think it's a checklist will be very important. As treatment monitoring, yes, I treat monitoring as assessing treatment response and detecting residual disease. Actually here in Egypt, in Hodgkin's lymphoma, you follow most internationals at PET-2, interim analysis of PET-2 in Hodgkin's lymphomas, but in non-Hodgkin lymphoma, it's PET-3 and sometimes PET-4 in low-grade lymphomas. I used to do it. Actually, I need to evaluate PET-CT for response, minor disease, and monitoring of progression. What is in response? It's important evaluating of early treatment response. In Hodgkin's lymphoma, actually, we are following here NC guidelines. It's after 2 cycles. After PET-2, if it's complete remission, actually give another 2 cycles and just follow up, and which is very good. But if no response or partial response, I must to change chemotherapy rules. And actually, by PET-CT, I predict treatment outcomes and long-term progress. Which is very important is integration of PET-CT in personalized treatment planning. What's called personalized, not every patient is the same. You should differentiate between 2 patients in response. This is what we need. This is one of the most important. I have paper for me. It's Egyptian one. It's few years. What about bone marrow? What have mentioned by Dr. Ahmed, the bone marrow involvement. There in lymphomas, there is difference between PET-CT. Though in the past we used to do bone marrow biopsy as usual, bilateral. It must be bilateral, by the way, for lymphomas. But after accuracy of PET-CT, I don't think no, because if you can see here, I think concurrent between PET-CT and bone marrow results positive in both and negative in both. So it's very accurate. While only in concurrence in only 2 cases out of 28 cases. So it's highly sensitive for me to do. So mostly we don't do bone marrow biopsies in lymphoma here in our practice, only in suspected cases. The PET-CT imaging in lymphoma clinical indications, it's for me, I use it for, this is actually we do here. It's for pre-treatment staging, assessment of bone marrow involvement, yes, it's very important. Radiotherapy planning, I'm not a radiotherapist, but when I'm asking for radiotherapy for localized disease, it must be preceded by PET-CT. Biopsy, guided in suspected transformation, which is very important, especially in CLL as register. Response assessment, interim analysis at end of treatment, which is very important, and restaging of disease, which it's one of points. In staging of lymphoma, upstaging, downstaging up to 20% of cases. So it's very important for you to do PET-CT as a front. It's for extranodal sites, which is very important for bone marrow, which have been mentioned by Dr. Ahmed as plain liver, planning stage-dependent therapy, change in management. Yes, I can change management. Sometimes it's give me it's stage 3 or 4, but after PET-CT it's stage 2, so I can change management therapy, and also response assessment is more accurate in 35% case in presence of baseline study. Is it sensitive or specific? Yes. Comparing to CT, superior specificity, yes, it's almost 100% specificity more than while 88% for CT. In the field of hematological malignancies, PET-CT plays a critical role in staging as well as in suspected recurrence. This is our point of view. It's important that the imaging professionals be aware of the classification typically and atypical imaging features and important clinical information. That's why I'm asking now. Anyone who's going to comment on PET-CT, please ask about the disease biology. What types of disease? Because it's total difference for us, especially in lymphomas, in non-Hodgkin's lymphoma especially, and in subtypes of Hodgkin's lymphoma as lymphocytic predominant. So I think you are going to don't read just image. No, you can read the patients. So you need more information. Try to be more physician. Try to be a clinical radiology more than radiologist. Please, this is very important for us. And you can ask for us more questions about these cases. The degree to which PET-CT contributes to the overall clinical management of patients with hematological malignancy is dependent on many important factors that require dedications, attention to details, ongoing self-education, and good communication between the provider imaging professionals. That's what I'm asking now. An understanding of the normal biodistribution and physiological parameters that may alter the distribution of PET-CT are needed to accurately interpret the scan. I'm going to give an example now. Dr. Ahmed, while in the States, I sent him many PET-CT asking for his help. In return, he asked me to do another MRI or PET-CT or CT, not PET-CT, to compare both. So he needs more history about this disease. What type of lymphomas is extranodal? What type of disease? What treatment is given? I was wondering why, but the answer was very good, perfect. He answered me, this is what you need. This is not disease activity, this is what's called. So you need more to be more aware of lymphomas and its treatment. The maintenance of a knowledge of the literature is critical for ongoing professional improvement and relevant usefulness of imaging studies. This typically requires both a familiarity with the radiology and nuclear medicine literature, but also with specific publication relevant to hematological malignancies. It's important that the imaging provider be recognized of the fact that The classification of subtypes of lymphoma and other hematological malignancies is an ever-evolving process. We are, as referring providers, should understand the limitations and advantages of PET-CT, which is very important for us. Communicate well with the imaging professionals, what we do now, and ask specific questions that will guide the imagers in providing the most relevant and accurate information possible. So, from here, I'm asking to do its incorporation, a checklist before reading any PET-CT, please. I think it's, this is my last slides. I heard about, we are going to have next generation PET-CT. I've heard about PET MRI. I don't know what it's going or what. Also, integration of artificial intelligence would be very important. Also, development of novel radio tracer, I think is very important. Exploration of multimodal imaging approaches for comprehensive disease assessment, it will be important. Thank you for listening, and I think it's Arin Asad, as you call, and thank you for you. Thank you very much.
Thank you, Dr. Ashraf, for very